Okay, we are live. First of all, hello everyone and welcome to this webinar. Before starting, I want to check if you all can hear us and you're all with us. So hopefully you will be joining us throughout the following minutes. But in the meanwhile, if you can say hi's or like send us any emojis so we can know that you are here and you can hear us very well, it would be great. As a start, my name is Mahmoud. I'm the Scope General Assistant for this term, and we will start with a round of introductions, starting by Wing.
Yes, hello, I'm Wing. I'm the General Assistant for SCORI at IFMSA.
Lalu.
Hi, I'm Laura or Lalu. You can call me as you prefer, and I'm the General Assistant for SCORA.
Sarah.
Hello, everyone. My name is Sarah Maidol. I'm the Regional Assistant for Public Health in Africa, and I'm very glad to be doing this with you guys. Welcome.
Maru.
Hello, yes, my name is Maru, or as it is short for Marwan. I'm from IFMSA Morocco, and I'm the SCOMI General Assistant. I'm really glad to be with you guys here.
And last but not least, Dwani.
Hello, I'm Dwani from IFMSA Honduras, and your General Assistant for Capacity Building, and I'm really excited for you to join us.
Okay, so thanks to our all speakers that are with us today. Today we'll be talking about our campaign Health for All and taking an intersectoral point of view to how to achieve the dream or the vision of Health for All from different aspects of our different standing committees, and we will also be discussing IFMSA efforts towards achieving that vision. So I'll start by sharing my screen. Hope you can all see my screen now. Okay. Okay, so starting our webinar with health and human rights, and knowing why is it very important and why it is essential to reach and promote universal health coverage. So first of all, in 2005, late UN Secretary General Kofi Annan addressed the UN Human Rights Commission, saying that the era of declaration is now giving way to an era of implementation. We have reached a time in which we should not argue whether what is a basic right or what is not. But it's now time to start implementing these rights and promoting them. And implementation does not only mean passing laws or writing policies, although laws and policies are really important. Implementation of human rights means making human rights real for all, in practice, in clinics, in hospitals, and in communities, and so on. In the era of implementation, healthcare workers have as much of a role to play as governments, and we will see later through this webinar how this occurs. To start with, the right to health is stated in the 25th article of the Universal Declaration on Human Rights. It states, and I quote, "Everyone has the right to a standard of living adequate for their health and well-being of himself and of his family, including food, clothing, housing, and medical care and necessary social services." From this article, we can conclude a definition to the right to health, which is the right to the enjoyment of a range of facilities, goods, services, and conditions necessary for the realization of the highest attainable standard of health, And by health, we mean both physical and mental health. From that definition, we can see that the right to health is an inclusive right, meaning that it not only includes health services, but also all of the factors that influence our health, which we call the social determinants on health. And these include housing, education, income, among others. So the right to health, as the other rights, has some elements to it. These elements are shortened in the AAAQ framework, which stands for availability, accessibility, acceptability, and quality. So first of all, what is the AAAQ framework? The AAAQ framework is an approach towards economical, social, and cultural rights to monitor and ensure their fulfillment. So what do they stand for? First of all, availability, meaning that healthcare services, healthcare facilities, goods and programs, including human resources, are all available and of sufficient quantity. Second, accessibility, meaning that all of these services, goods and facilities should be accessible to everyone without any discrimination. And by accessible, we mean physical accessibility, as in being close to one's home, or not denied to enter or to achieve or to receive this service for any specific reason, or for any discrimination, without any discrimination. And also to include affordability, and if it's in the form of accessing information to how to implement a procedure, it's also included in accessibility. Third, acceptability. It is really determined by the social and cultural perspectives of communities. So different forms of services might not be acceptable in certain areas, and so on. And finally, the quality of the services, the quality of the goods, the quality of the facilities, is also what ensures the promotion and fulfillment of this right. In order to implement this framework, we need to work in a human rights-based approach, and that's a people-centered approach. A human rights-based approach follows the panel principles, which stands for participation, meaning that people should be involved in decisions that affect their rights. Accountability, which means that there should be monitoring of how people's rights are affected, as well as solutions when things go wrong. And non-discrimination, meaning that all forms of discrimination must be prohibited, prevented, and eliminated. Fourth, we have empowerment, meaning that everyone should understand their rights and be fully supported to take part in developing policies, practices which affect their lives. And finally, legality, meaning that approaches should be grounded in the legal rights that are set out in domestic and international laws. Applying a human rights-based approach to health involves ensuring the fair and equitable distribution of social determinants of health, thinking about how resources are allocated, working with people to understand the factors that undermine their right to health, and together identifying actions to make improvements, taking actions to tackle economic and social inequalities, alongside actions which specifically focus on disadvantaged groups and deprived areas, ensuring services are planned and delivered in proportion to need, and ensuring that these services are available, accessible, appropriate, and of equal quality. In our next part, we will talk about the availability and accessibility of the healthcare services, and we will know more what is universal health coverage with Sarah.
Okay. So when we talk about universal health coverage, and which is a global priority in the IFMSA, we're talking about the ability of people, no matter their background or situation, to access healthcare services that they need and whenever they need them. And so this means that all people and communities can access services all the way from promotive to palliative services. So promotive services, preventive, curative, rehabilitative, and palliative health services. And so UHC includes all the three A's and Q of universal health coverage as discussed by Mahmoud. So next we'll talk about why it is important to really speak about UHC and what's all the buzz about it. So we have statistics that show us that 400 million people have no access to essential health services, and essential health services are the most basic of services, and nearly half of the world's population lacks basic social protection, which includes things like insurance that protects families from financial risk and diving into poverty. So 800 million people, which if we think that we're 7 billion people on the world, that means nearly a seventh of the world's population is forced to pay more than 10% of the household budget just for healthcare. And nearly 100 million people are being pushed into extreme poverty. And we talk about extreme poverty as being living on less than $2 a day. This is because they have to pay for healthcare. So when we think about this, all this ties up in the SDGs, and particularly SDG 3 when we talk about good health and well-being. In SDG 3, universal health coverage refers to the main point in universal health coverage in SDGs is that we want to achieve universal health coverage, which includes financial risk protection, access to quality services, and affordable medicines and vaccines for all. So you'll see that UHC is tied to nearly all the SDGs. If you think about, for example, SDG 1, when we talk about no poverty, obviously the fact that we are talking about protecting from financial risk then means that we are playing a role in preventing poverty, as we said. So how do we build UHC? UHC is based on, we can't talk about UHC without talking about the health system building blocks. And these are the WHO building blocks, which include governance, a health workforce, health financing, essential medicines and technologies, and health information system. And the outcomes and impact that we want is to reduce health risks, first of all, to improve the health of the populations, and to have equitable health outcomes and improved financial protection. So the action domains of universal health coverage that lead to us achieving these outcomes and impact include quality, where we talk about regulation of health services, and individual and family engagement, and talk about efficiency, which includes architecture of the health system and managerial efficiency and effectiveness. And equity is also an action domain of universal health coverage, which just means that everyone should achieve the same quality of health services regardless of their social status or any other thing that could lead to discrimination. Accountability, where governance plays a role as a health building block, health system building block, and partnerships, let's say, between the public and private sectors to ensure that we have these outcomes and impact from universal health coverage. Another thing that we need, that is a domain of universal health coverage, is sustainability and resilience. So we need public health preparedness and community capacity. So, and we also need system adaptability and sustainability. So really, all these 5 components are the domains of universal health coverage that will lead to these outcomes that we want in health. So primary healthcare plays a big role in achieving universal health coverage, because primary healthcare is a concept that was adopted in the Alma Ata Declaration. and it's about now 41 years old. So it started in 1978. And when we talk about primary, we're referring to essential healthcare being accessible to individuals and families, and it forms an integral part of the country's health system. So primary healthcare covers the majority of a person's health needs throughout their life. And again, we said from all the way from promotive services up to palliative services. And at least half of the world lacks full coverage of essential health services. So when we talk about primary healthcare, we really just want to ensure that it's the first level of contact of individuals with the health system, and it brings healthcare as close as possible to people where they work and live. So primary healthcare being the provision of essential health services then plays a big role in ensuring universal health coverage. So if nearly everyone has access to primary healthcare, then we have a lot of people having access to, a lot of people being universally covered in health. Next. So the three components of primary healthcare, which are based on the principles of primary healthcare. And once again, primary healthcare refers to meeting people's health needs through comprehensive services. And when we talk about comprehensive care, we start all the way from health promotion, disease prevention, curative services, rehabilitation, and palliative care. Then another thing that we is a component of primary healthcare, is systematically addressing the broader determinants of health. So determinants of health include social, economic, and environmental characteristics and behaviors that could that lead to health outcomes. And so because we talk about all the things surrounding us determining our health, then that means that we need an intersectoral approach in achieving primary health care. And lastly, empowering individuals, families, and communities to optimize their health. So in primary healthcare, it's not just dependent on the health system or the health workforce. It includes participation from individuals, from families and communities in order to achieve primary healthcare. Because we said, if it starts from prevention, then prevention and disease prevention and health promotion are things that start from the community. So we need not just the health officials or workforce to be involved in primary healthcare, but also the families and individuals. Okay. So can universal health coverage be measured? One of the ways that we can measure universal health coverage is to monitor two things. So one is a proportion of the population that can access essential quality health services. So, if we have a larger population accessing essential health services, and that means that we are approaching universal health coverage. And we tend to think of universal health coverage not as a destination, but as a journey that governments and individuals should take. So the next thing that we can measure is a proportion of the population that spends a large amount of household income on health. So we're measuring in this case, we're measuring the financial risk that is incurred by families through spending on healthcare. Other ways that universal health coverage can be measured is frameworks by the WHO and the World Bank, and the 16 essential health services in 4 categories can be used as indicators. So this includes reproductive health, which includes maternal, newborn, and child health, infectious diseases, non-communicable diseases, and the service capacity and access.
Okay, so now we will move. We will talk about acceptability and the universal health coverage with Lalu.
Yes, so first of all, the question is what makes the service acceptable? So the facilities, goods, and services must be acceptable for users of the service. So this means that it has to be culturally appropriate, sensitive to vulnerable groups as well. So this requires being respectful to the culture and cultural perceptions of the right holders. So as an example, if we talk about sexual and reproductive health and rights, it's important to highlight that acceptability is not to be interpreted as a loophole for duty bearers or others to obstruct or not respect women's SRHR based on an argument that it goes against cultural or religious norms and systems. So if a state or a provider refuses to deliver services due to consensus objections, if this happens, it must be ensured that women is referred to an alternative healthcare provider. And as we use this example talking about SRHR, we'll focus a bit more on the role of SRHR in universal healthcare coverage. So sexual and reproductive health and rights are a fundamental component of universal healthcare coverage. And the highest possible standard of health cannot be attained without accessing these high quality SRHR services as well. So especially for women, girls, and adolescents with various needs, that it's important to have a focus on SRHR as well. So, for example, family planning and access to contraception is one of the services included in SRHR. So the aim of it is to ensure universal access to a full range of safe and reliable family planning methods and related health services is to, sorry, I was gonna hear background noise, but yeah, I'll just keep going. If you cannot hear me, just let me know. But yeah, going back to family planning, to achieve the reproductive goals and have full opportunities to have children by choice. So family planning relates to the possibility of individuals to anticipate and attain the desired number of children and the spacing and timing of the births. So women's ability to space and limit the pregnancies has a direct impact on their health and well-being, as well as the babies. Thus, coercion and forced measures of family planning go against the acceptability of this service. And on the other hand, the principle of informed free choice is what's pursued in family planning programs. So in this case, acceptability refers to the respect of giving information, education, and services that have like medical ethics and cultural of different groups taken into account. And this includes being gender sensitive, giving counseling and education on family planning. So this is needed to ensure that it's tailored to the person we have in front, and it's assessing this person's needs. And also, it's not only about individuals, but also about communities, as it was said before. And for example, for young women and girls is something to stress out as well. And another example is access to safe abortion. So the Universal Declaration of Human Rights describes health as a core human right, and an intrinsic principle of it is autonomy. So it's women's human rights to have the full autonomy over decisions relating to when and how many children to have, ensuring that there will be safe avenues for her to enact in this choice. So if this service is acceptable, it means that it again respects medical ethics and the culture of the individuals during abortion, but also post-abortion care. And women are more likely to find a method of abortion acceptable if they choose it themselves. So ensuring that women is included and informed in the decision-making processes is one way of ensuring the acceptability of this service.
Okay, thank you, Lalu. And now we will move into the quality part together with Wing and Maru. So, Wing.
Yes, so we'll talk about quality health in services. So the first question would, of course, be how do we ensure quality in health services? And one way to do that is evidence-based medicine. Here you can see the definition of evidence-based medicine. It's a systematic approach to clinical problem solving which allows integration of the best available research evidence with clinical expertise and patient values. So, next slide. And as a visual representation of evidence-based medicine, you can see here. So you have patient values and preferences. So what does a patient value, and what do they prefer? Kind of like the autonomy of a patient in deciding what kind of treatment they want, and also the best evidence according to scientific evidence, and also the clinical expertise from the people that work in the hospitals and everything. And in the center of that, all combined, that's what's called evidence-based medicine in pursuit of the best possible outcomes. Okay. Why is evidence-based medicine important? Well, it is all about providing the best care for your patients from different treatments that was proven scientifically, and it is to challenge the current practice of medicine. So we all have a way of doing medicine. You provide this sort of treatment for this kind of diagnosis, but it is to challenge that on what we already know. So we want to do that with evidence-based medicine to give better treatments, to have the highest efficiency with the limited amount of resources that we might have, and also to strive for higher and higher quality of life for the patients themselves. So to break down evidence-based medicine very shortly, it can be explained in 5 steps. So you see the 5 steps here. In step 1, it is ask a clinical question, um, and that can be used with PICO. Next slide. So PICO, um, it's basically an acronym for population or patient or problem, the I for intervention or exposure, the C for comparison, and the O for outcome. So you usually ask yourself, who are the patients, or what is the problem, what is the population, the I for what do we do with them, what are they exposed to, C for comparing basically the intervention with something else, for example, giving a certain kind of medicine instead of giving a placebo, so basically nothing, and then you see what comes out of it. So what happens, what is the outcome? So that's basically step 1, so the clinical question. And then step 2 is acquiring the best evidence. So basically gathering all your evidence, track down with maximum efficiency the best evidence with which to answer the questions in step 1 of. In step 3, you appraise the evidence. So you critically evaluate the evidence on its validity. So can you trust this information? Is it the clinical importance? So if it's true, will the use of this information make an important difference in your decision making? And applicability is, can you use that information in the specific case that you have or the specific instance that you are facing? And then step 4, apply the evidence. So basically using these results in your practice. There are different things to take into consideration, like are the participants in the study similar enough to the patient you have in front of you? Is the treatment available, and is the healthcare system prepared to fund it? So do you have access to that kind of treatment? What alternatives are available? Do the potential side effects of the drug or procedures outweigh the benefits? And are the outcomes appropriate to the patient? And as said before, evidence-based medicine is also about the patient's values and expectations. So does the treatment also conflict with what the patient wants or expects? And then step 5, when you actually apply the new treatment, for example, you evaluate or assess the performance. So how well does it do in the patient in front of you? Does it work for your patient? And those are the 5 steps. And usually it's a whole circle. So after evaluating the process of how well it works for your patient, for example, it does work or it does not work, then you ask a new clinical question. If it doesn't work, then maybe you should find something else. And if it does work, how do you even improve what you have? So it's a constant circle of learning almost. And that's what evidence-based medicine is all about. So it's to keep building on what we know about medicine, about the treatments, medicine that we have, to always improve our way of providing this healthcare. And we don't practice medicine just on what we think is true or works better, but it's actually based on what has been proven scientifically over and over and over again to ensure we do the best for our patients.
Okay, so now Maru.
Okay, thank you, Mahmoud and Wing. So I don't think we can talk about quality health services without talking about quality health workforce, because quality health workforce, it has been in the center of discussion of the Sustainable Development Goal, especially the Sustainable Development Goal number 3, which is health and well-being, because one of its targets is to substantially increase the health financing and recruitment, development, training, and retention of the health workforce. So it also joins the vision of the Global Health Workforce Strategy 2030, which envisions to have not only have doctors with the right numbers in the right places, but also with the right skills. So how do medical schools ensure that we can achieve having this vision, having the right number of doctors, but in the right places, but most importantly with the right skills? And can we move to the next slide? Yes. So through a quality medical education, medical schools are endeavor to provide the right skills to the right doctors so they can ensure delivering quality health services. And how do medical schools assure that they provide a quality education to their students so they can graduate as capable doctors and capable healthcare professionals in their health systems? But it is simply through the accreditation process of medical schools, and we can see, so we can learn about it more, some keywords here. First of all, we have accreditation. What does accreditation mean? But it is simply a peer review process that allows medical schools to ensure and to test and ensure the quality of their medical education programs. So it does not apply to other areas of the medical school, such as its financing or but most importantly, its educational program. And if you see other keywords in this certificate, that you can see the WFME, and you can see also the global standards, as well as the requirements of, for example, TEBDAT Turkey, as we can see here through this example of the American University of Beirut, its Faculty of Medicine. So how does it go? How does it go each medical school to have its accreditation and to assure its quality? And can we move to the next slide, please? Yes. So it is simply by the World Federation of Medical Education has established global standards, so they can assure a level of requirements that each medical school should be having in order to have its accreditation process, so they can meet the quality that is needed to be having on a global scale. So the World Federation not only sets these standards, but also gives recognition to accreditation agencies. So it would allow these accreditation agencies to work locally and close to, in a close communication with medical schools, so they can provide them with more specific accreditation requirements, and also make sure they monitor their quality management and quality improvement on a local level. And can we move to the next slide? Yes. So the process, it goes through different stages and on different levels. For example, on the local level, a medical school is required to run a self-evaluation of its educational program through different components of its educational program. And then afterwards, it should be providing its own report that it would provide to this accreditation agency. And then also there would be a meeting on the ground with the accreditation agency, as well as with the different stakeholders that are involved in the accreditation process, such as the faculty administration, the university, as well as the medical students that are represented in this meeting as well. And then afterwards, as the fruit of this meeting would be a final report that this accreditation agency delivers to the medical school. So it could give recommendations for the points that would need to improve the quality of the educational program. And the result of this accreditation process is usually either providing medical schools with a refusal for accreditation and until a next meeting, or an accreditation on a temporary period, and then afterwards it would be subject to re-evaluation, or a long-term accreditation. But most likely, each medical school would get a temporary accreditation, so it would be subject to regular and continuous development and continuous quality improvement of its educational program. Can we move? Yes, thank you. So, as we have spoken about the global standards of medical education and the accreditation requirements, it assures the quality of the medical education program, and it most importantly assures the quality of the skills that medical doctors are equipped with, so they can be active in the healthcare system. But we should not omit that not only these skills and these competencies should be on a quality level, but also they should meet the priority needs of the health communities that they are mandated to serve. And here comes the concept of social accountability of medical schools as a core component of the accreditation process and the quality assurance of medical education, because social accountability, it directs these quality skills and quality education towards the health population needs, as stated by the WHO definition in 1995. And yes, that's all about the accreditation process. And when we talk about all these concepts and the universal health coverage, it is a very overarching concept, as you have noticed in our webinar, that it encompasses all different areas that IFMSA is working on. And can we move to the next slide? Yes, thank you. So as I have mentioned, universal health coverage is a very overarching concept and a very broad topic that encompasses and englobes many different focus areas that IFMSA is working on and has defined as its own global priorities. And as you can see through this slide, is these focus areas are centered around universal health coverage in a way that they serve the different the different components of the AAAQ framework. And if you look throughout the global priorities and their objectives, you would notice that IFMSA endeavors are directed towards achieving the universal health coverage in its different components of its framework. As you can see, like this looks like a compass, and the focus areas are not placed in a very mathematical way or whatever. They just it's just the purpose. It means that all of these focus areas can achieve universal health coverage and can contribute towards the implementation of different actions of IFMSA, whether on an internal level or on the external level towards our advocacy efforts in order to achieve universal health coverage. And yes, we can talk about the IFMSA actions now.
So regarding what IFMSA actually does for universal health coverage, it is one of our core advocacy priorities for IFMSA, and it influences our decisions in a very big way. Two of our biggest external representation events focus on health for all, actually. So our first one is the high-level meeting on universal coverage, which is coming up in the second semester of the year. And we also have the World Health Assembly, where IFMSA members will engage directly with member states of the World Health Organization. Our 60 delegates will be advertising for both universal health coverage and meaningful youth participation. Next, please. Next slide. Sorry. Yeah. Okay, so IFMSA always aims to create open spaces to learn about and discuss this type of topics. Our main space for capacity building on global health and health for all are PHLTs. A public health leadership training is a standard IFMSA workshop that promotes medical students to come together to learn and build skills and share ideas to address all of the issues related to public health and to universal health coverage. There are also other workshops, of course, if we look at it from an AAAQ perspective. All of our capacity building workshops, in one way or the other, work towards this goal. Some of them are at our advocacy and medical education training, our women's reproductive health and access to safe abortion workshops, our HEAT, our HIV education and advocacy training, among many, many, many more. Next. Okay, so IFMSA programs and activities are the heart and soul of the Federation, basically. So which IFMSA programs are like directly linked to Health for All? Basically, all of them. By working on decreasing the gender gap, by aiding marginalized groups, by advocating for the environment, and for people to take care of themselves, not only physically, but also mentally and emotionally, among many other surplus activities, we work for a world where everyone has accessibility, availability, acceptability, and quality in their health systems. Okay, so let's move on to a little bit about exchanges. As Mark Twain puts it, traveling is fatal to prejudice, bigotry, and narrow-mindedness. In this case, professional and research exchanges are fatal to cultural insensitivity in our health system. IFM exchanges pose an excellent opportunity for highlighting the importance of cultural sensitivity in healthcare and even fomenting cultural sensitivity within a person. What will students notice or experience during an exchange? They will notice how things get lost in translation, basically. Being the foreigner can be a refreshing experience for the student to see and feel themselves in the shoes of a non-native person. What does it feel like to be a foreigner in a strange medical system? Even though the medical students say in the shoes of the medical personnel during their exchange, it can be a very good experience in regards to how a language barrier influences you, and it influences how you get your health taken care of. You may notice some people with the white savior complex as well, which is when people from rich countries help out not for the other people, but only to look at themselves. Please refrain from this. Empathy should be pure, and on exchanges, a very empathizing experience on itself. All of this is why pre-departure trainings and upon arrival trainings are extremely necessary. Going on exchange can be a student's first real-life experience in in a medical community. Even if it is an empathizing experience for the student, they might not have any real-life medical experience yet. So it is very important that they have the pre-departure training and the upon arrival training as well. A pre-departure training should basically cover what the student should know about ethics, global health, and the universal health coverage. Some very good approaches have been done with role play and case studies for what not to do in exchange, and we recommend these greatly for our exchange trainers. A good pre-departure training is very important from the standpoint of cultural sensitivity, but we should not forget a proper UAT. A UAT can highlight the local public health issues and enlighten the student about the factors that they should take into consideration when coming to a new country with cultural sensitivity issues. Okay, so I want to leave you with something the World Health Organization Director General said on World Health Day. He said, today, half the world's population, today as in 2019, half the world's population cannot access essential health services. Millions of women give birth without help from a skilled attendant. Millions of children miss out on vaccinations against killer diseases, and millions suffer and die because they can't get treatment for HIV, tuberculosis, and malaria. In 2019, this is simply unacceptable. The good news is that there is a growing movement to address these inequalities. And that is what basically IFMSA is and what it does. We are a big part of this movement that addresses these inequalities and that is trying to change and to get to that dream, that achievable dream of universal health coverage.
Okay, thank you, Dwani. Ensuring everyone has access to acceptable and high quality healthcare services is not an overnight process. It takes time and continuous care and attention to maintain the progress towards this goal. Health for all is no more a dream, it is a goal that even though we are still away from it, we are progressing towards it. But we can make it a reality by being accountable for our education, being accountable for our practices, by ensuring to follow a human rights-based approach and a people-centered approach in our practices. And so one last thing before we finalize is that, yeah, health for all is possible, and let us all join our efforts together to make health for all a reality. At the end, I would like to ask if any one of you have any question to ask before closing the webinar. So I will just check the chat to see if anyone is leaving any questions at the moment. In the meanwhile, if you have any questions or you want to know more about any of the topics discussed, do not hesitate to contact us through one of the emails below. You will find the emails of everyone present in this webinar in the slide we're standing on. So I see that we have no questions. With that being said, we would like to thank you all for attending this webinar. And we'd also like to thank everyone who was a speaker with us today, starting from Wing, Lalu, Sarah, Marwan, and Dwani. And we also want to thank the people who helped in preparing this webinar, who are not able to join us today, Anna and Elena, the SCOF and Scopy General Assistants. At the end, as I said, let us all join our efforts and make health for all a reality. Thank you, everyone, for being with us. Goodbye.